Wonderful. Well, thank you so much. And thank you all for inviting me in to join you this lunch hour. I know you probably have very busy days ahead, so thank you for taking some time and hanging out with me. So we will be talking about, let me share my screen here, EndoAxis. And this has been a little pet project of mine. Let's see. This all works together. Technology not always my friend. There we go. Is my screen showing up here for everyone? Cool. Awesome. Thank you. So just a little background. EndoAxis, what are we? We are a tech-based supplement company. We are new kids on the block. We launched in April of 2024, but we've been a work in progress for the last 3 to 4 years. And really, it's been the vision and guidance through both Karan Krishnan, through Microbiome Labs, Dr. Tom Bain, and Dr. Guy Citrin, who brought kind of the idea to help streamline hormone analysis. How can we get a deeper insight and a deeper view, right, into what's going on metabolically with hormones, what's going on um, in regards to just like atypical or weird symptom presentation, and how can we target supplements to really support. Let's see if this will actually work. My slides aren't moving, are they? There we go. To really support hormone balance. And so I was brought to the team about 2.5 years ago. My background is with Precision Analytical, the lab that does the Dutch test, so a little bias within the lab space and with that lab in particular. But really, the reason I worked for them was that I always had this drive to understand hormones beyond just what a blood test shows us. I felt like that was a very limited view. My background is in genetics, cellular and molecular biology, and in environmental medicine. And so I really brought that perspective to what I was doing as a consultant with the Dutch test and found that urinary analysis was just so profound and how it could really help unravel metabolically what's happening with that hormone journey. And so that's what really excited me about joining this project. And now here we are a few years down the line with a project or with the project unfolding itself. So EndoAxis, I'm currently the director of clinical sciences at EndoAxis. I also have a small part-time practice in Salem, Oregon called Wholegenic Wellness. But just as an objectives for today, I get so excited and nervous at the same time, so I apologize. I'm going to ramble all over the place, so bear with me. But today we're going to do an overview of sex hormones and what are we looking at and where we might be missing that mark, right? And what can urinary metabolites really reveal for us? What are the advantages and disadvantages of every type of test out there that's measuring sex hormones? And how can we really connect the dots and provide streamlined product intervention to maximize patient outcomes? So just as a basic overview, right? Like I always think these are nice, like reminders, but we're going to be talking about our primary parent sex hormones, testosterone, estrogen, and progesterone today. As a reminder, both genders do make these sex hormones, but of course, testosterone is going to be the primary sex hormone for men, and estrogen is the primary sex hormone for women, with progesterone being our fertility hormone. Men do make progesterone as well, very small amounts. It's really used in their Sertoli cells as kind of the sperm capacitation hormone. So it's allowing that final maturation process for sperm. So still an important hormone, just not as prolific as testosterone, obviously. And we have to remember sex hormones are cholesterol based, so they're fat based. This gives them some advantages, right? This allows them to be able to passively diffuse through our cell membranes. So given that all of our cells are a phospholipid bilayer, they are a fatty bilayer, we're able to then have these sex hormones just pass right in. So you don't need those external receptors like a lot of our peptide hormones like thyroid or insulin, right? That have to bind to those external receptors. Instead, a steroid hormone can pass right in, and it's within the cytoplasm that it meets with that either estrogen, testosterone, or progesterone receptor complex, forms a unit, and that unit now goes into the nucleus and augments cell behavior. So some things to remember, because they are fat-based, if they're coming out of tissues, they can be used readily within fatty tissues like the adrenals, the ovaries, the uterus, the testicles, the adipose, right? The brain. But to circulate from those tissues and get to other tissues where receptors also exist, like the bone, the heart, right? The vascular tissue, the skeletal muscle, again, the brain, we have to have carrier proteins because the blood is mostly water and protein based. And if you think about pouring olive oil into a cup of water, you get that displacement, right? They do not mix, right? Because steroid hormones, fat, is hydrophobic. So it doesn't like water. And so you have to bind to sex hormone binding globulin or albumin to carry it and transport it through to those tissues. And that's really what you're capturing in blood. So when we think about, okay, we've made the sex hormone, It's going to be active in those reproductive tissues. It's going to circulate. It has multiple, right, roles throughout the body. Estrogen, testosterone, and progesterone, right, act in many different ways. They're augmenting our immune system. They're augmenting our neurotransmitters. Again, they're helping our bones, right? So they're balancing a lot of like our fat signals. Our leptin, adiponectin are regulated not just by estrogen, progesterone balance, but by FSH signals. So all sorts of negative feedback, positive feedback, homeostasis, like all these signals being controlled by these steroid hormones. But that said, they don't have infinite lifespan, right? So it's not like you make a hormone and it just stays steady state all day long. They have half-lives, they go up and down throughout the day, and they have to be metabolized out of our bodies. And so when we think about that metabolism process, that is a process that's taking this very hydrophobic hormone and converting it into more and more hydrophilic byproducts, right? So that we can finally bind to bile, clear out into urine and into stool. And so that process, of course, another fun reminder, is part of our phase 1, 2, and 3 detox. And the liver is the heavy lifter here for a lot of that detoxification, although we do have a lot of these enzymes, like our CYP3A4 exists in our small intestine and colon. So this is why it's such a profound enzyme for clearance of a lot of our medications, not just that it is so prolific in the liver, but because it also exists in other tissues that are going to get hit by any oral medication. But we also have, we have 5-alpha reductase, 5-beta reductase, not just in the liver, but also in adipose, in the uterus, in the adrenals, right, in the brain, in the skeletal muscle. So transformation of these sex hormones really can happen in many tissues, but ultimately the big clearance is going to be once it hits the liver and processes out. So again, as a reminder, we're taking those steroids, we're making them into water, and that's going to be through a process for the CYP450 family of enzymes, right? That's hydroxylating, that's phase 1 detox. So that's taking that steroid hormone, it's adding a hydroxyl group to it. Primarily, this is converting estrogens, right? And we have our CYP, the infamous good, bad, and ugly, right? So the CYP1A1 is our good pathway. It's expressed heavily in the liver, and it does convert estrogens, estrone and estradiol, into 2-hydroxyestrone and estradiol. We have the ugly, the 1B1. I always think B for bad, right? But the 1B1 pathway, that is converting our estrogens into the 4-hydroxy. And really 4-hydroxy in and of itself is not dangerous. It's when it's left unmethylated that it can transform. And it transforms into something called a 3,4-estrone quinone. And quinones can go into the DNA and actually create unstable DNA adducts that over time, if not repaired, just increase oxidative stress to that tissue and can lead to cancer risk. So that's why that 4-hydroxy pathway, we don't want to see a lot of that preference. Interestingly, 1B1 goes up in expression when we're exposed to a lot of polyaromatic hydrocarbons in particular. So these are smoked and charbroiled meat products, fires, right? I'm really worried, right? All over, but especially right now in Southern California, just the amount of fires and just toxins in the air, and we're inhaling all of these polyaromatic hydrocarbons. And what is that doing beyond just like the toxic burden to our bodies, but also to our hormones, right? Anyway, I digress. We also have the CYP3A4, again, big power player in metabolism of over 60% of drugs on the market and a lot of our steroid hormones as well, including estrogens. And this is the bad, but it's not really bad, right? It's converting estrogen into 16-hydroxyestrone, which is tissue proliferative. What's unique about 16-hydroxyestrone and estriol, which is 16-hydroxyestradiol, right? It was thought of as one of our primary hormones first, and then realized, oh, it's actually a unidirectional metabolite of estradiol. So chemically speaking, 16-OHs still have estrogenic response, right? And so 16-OHE1 in particular can actually bind to those intracellular estrogen receptors and increase the proliferative response at that promoter region within our nucleus, within the DNA of that tissue. So that's why it's considered like bad. But remember, 16-hydroxy, because it's helping with tissue proliferation, which includes bone proliferation, we want that when we're in our postmenopausal years. So there's always, a blessing and a curse to every hormone, two sides, right? And so 16-OH, it's not all bad. It is tissue proliferative, but, right, in our postmenopausal women, it tends to be the favored hormone, and we want it to be the favored hormone if we're looking to protect the bone. Of course, we can also do bioidenticals to protect the bone, but 16-OH has kind of that yin-yang kind of balance to it. CYP1A2 is also involved in estrogen metabolism, but is heavily caffeine metabolism. Remember COMT, catecholamine O-methyltransferase, which we'll talk about in our methyl cycle, that is also involved, so that's the methylation of all catechol, catecholamines, of which caffeine is also a catechol. So we have our 2 and our 4 hydroxyestrogens, which are catechol estrogens, dependent on catecholamine O-methyltransferase for phase 2 detoxification. And then we also have caffeine. So I just bring this up because if we're, dealing with a woman who has a lot of estrogen dominant symptoms and maybe their estrogens aren't overtly elevated, but they love their coffee, right? They drink multiple cups of coffee a day. They could be burdening some of the pathways that are required for that estrogen metabolism. And we can see that with metabolite preference, right? We can see a kind of a slowing down. All of our resources are going to different catechols, right? I always like to think of phase 1 detox as kind of sweeping up hormones into little piles. Right, so we have like our recycling pile, which is phase 1, which is the 1A1, right, which is kind of like benign. It can become a tripping hazard over time, but really it's a pretty innocuous substance, 2-hydroxy. It just hangs out pretty stable, waits for methyl groups whenever they can come around, right? It's just like, I'm just not intrusive. Versus like the 3A4 pathway being more like the garbage pile. We're going to have general refuse here. It's going to collect flies if it sits there for too long. And then we have the compost pile being the 1B1, being 4-hydroxy, which really you got to clear that out pretty regularly. Otherwise you attract mold and all sorts of grossness, right? So just a nice visual to think about when you're thinking about that estrogen metabolism. Phase 2 is taking those piles now and putting them into garbage bags. And again, as I mentioned, 2 and 4 hydroxyestrogens are the catechol estrogens. 16-hydroxy and estriol are actually heavily sulfated. So they're a bit bulkier. They don't get that methyl group added for clearance. They're getting a sulfur group added for deactivation and final metabolism. And then glucuronidation is that biliary conjugation. We have a lot of phase 2 enzymes, but the big ones for estrogens, we have that COMT, that catecholamine O-methyltransferase. I brought up our acetylation enzymes, and again, these are often families, like the NAT1 and 2 enzymes are a whole family, dozens of these enzymes, right? But NAT1 and 2, this is the acetylation, and polyaromatic hydrocarbons have to be acetylated. So if you're a poor acetylator, you can actually be pushing more 1B1 by proxy, right? So I use that as like an indirect metabolizer, right? When we're thinking about looking at metabolites and we're seeing a lot of 4-hydroxy, think about acetylation support as well. Glutathione GSTs, again, a whole family of GSTs, but these guys are binding the quinones. So when 4-hydroxy and 2-hydroxy are not methylated, they can form quinones. And glutathione can bind those and make them into water. If we don't have enough glutathione, those quinones become really oxidative, right? They become a burden to the tissue, and that's when we get those DNA addicts. Sulfation enzymes, we have salt 1A1 heavily metabolizing estrogen, 16-hydroxy. We also have 2A1 and 2E1 metabolizing DHEA or supporting DHEA circulation as well. And then our glucuronidation enzymes, and again, a big family of enzymes, but the 2B15, 2B17, and 1A1 are the ones heavily involved in our hormone metabolism. So just to think about this, right? Get the biochemistry behind it. Again, we're sweeping up our estrogens into these phase 1 intermediates, and the phase 1 intermediates are not yet fully inactive. They still can be responsive within the tissues, especially the 4 and the 16 hydroxys. 4-hydroxy, again, really not a problem unless it's not methylated. If it's methylated, it becomes the 4-methoxyestrogen, and that's inert. That can be safely packaged and eliminated out of the body. But when 4-hydroxy is not methylated, that is when it can quickly transform to these 3,4-estrone quinones. And again, these can go into that into the nucleus, altering DNA. And what's really interesting, and again, this is something you can look at when you're looking at urinary clearance of these hormones. So you can see these metabolites, right? We're watching this process unfold in front of us in that urinary excretion. You can also see a very unique excretion of 8-hydroxydeoxyguanosine, 8-OHDG. The reason this is a really important marker to watch for, it kind of tells us how much damage is occurring from the 3,4-estrone quinones, right? So we have 4 base pairs of our DNA, right? Guanine is the most sensitive of the 4 base pairs to oxidative stressors. 8-hydroxydeoxyguanosine, as its name implies, is a hydroxyl group flag. It's basically a flag that binds to any guanine that's unstable. And it's basically acting as an alert for catalase to come and clean this up and repair this DNA strand, right? So if you're seeing a lot of excretion of 8-OHDG in urine, that's a high oxidative stress burden. And that's where we start thinking, okay, let's work backwards. What's the 4-hydroxy? What's the methylation? What is the NQO1? This is NADPH quinone oxoreductase. This enzyme is in the phospholipid bilayer of every single cell in our bodies, and it is basically an antioxidant superhero. It is responding to that quinone oxidative stress, and in response, it upregulates conversion of enzymes necessary for CoQ10, ubiquinone, to activate into active ubiquinol, for vitamin E to go into active tocotrienols, and it turns up the volume, essentially, turns on expression of the tumor necrosis factor P53, the cell regulatory enzyme, so that if there's so much damage or too much damage to really repair successfully, we can then turn off that cell. We can go into programmed cell death or apoptosis. So really important when we're looking at our urinary metabolites that we start thinking about, okay, what are these byproducts? What are they telling us? And how can we reverse engineer this to understand what might be going on at a cellular level? Because you can have totally normal estrogens. If someone's not methylating or they're creating a lot of oxidative burden, they're not going to feel good, right? Like that's going to lead to a lot of fatigue, a lot of dysmenorrhea. You can get more sensitivity to mast cell activation and histamine response. So there's really like you can start noticing these symptoms even without overt primary hormones being out of balance just by looking at those metabolites. Our sulfation, more things that you can see in urine, right? More things revealed. You can see the sulfation response of DHEA. Remember that sulfur group has to be added to DHEA to allow it to circulate. It makes it stable in the bloodstream. Once it hits a cell, STS, sulfur transfer sulfatase, comes in, cleaves off that sulfur group, allows that DHEA into the tissues. And now it can become androstenedione, which can then downstream convert into testosterone or into estrogens, or directly into DHEA metabolites, androsterone and etiochalanolone, which are important for our immune system response. And you can see, again, you can see that world unfold in those urinary metabolites. You can also see the relationship between testosterone and estrogen and determine if there's a concern for upregulated or downregulated CYP19A1, which is aromatase. You can look at androgen metabolites and look at that 5-alpha, 5-beta reductase response. That's the SRD5A1 and 2 enzymes. And again, you can also see that sulfation as it plays out with estrone. In urine, you're looking at estrone sulfate. So you're actually seeing this end product of estrone heavily in the urine, which can again reveal if there's an issue with sulfation issues or concerns, with gut, with inflammation. So lots that starts to unfold there. And then finally, we take those garbage bags and we put them into the dump trucks and we take them to the dump, quite literally, right? We're taking them out of the body through stool and urine. And this is where we meet the estrobolome. And the estrobolome is defined as a group of gram-negative bacteria that uniquely make this enzyme called beta-glucuronidase. As that name implies, ACE is a cleaving enzyme. So I think about beta-glucuronidase. Basically, it's like the rats, right? It's coming in and it's cleaving off that glucuronide side chain. So it's making that now hydrophilic molecule, this now packaged and conjugated and ready to eliminate molecule, it's making it hydrophobic again. It's making it active again. It's bringing it back into circulation as estrogen. So beta-glucuronidase, they're the rats chewing through all those garbage bags, right? And that just puts more burden on the liver. The liver now has to process that estrogen all over again. That estrogen is now free to circulate into other tissues once more, and it can act on those estrogen receptors all over again, right? So even if you don't have high estrogen, if you have high beta-glucuronidase, you're going to feel estrogen dominant most likely. And again, two sides to this coin. Postmenopausal women, this can actually be a really good thing to see, is that elevated beta-glucuronidase, because it means they're able to circulate what little estrogen they do have. Of course, if you put them on bioidentical hormone therapy, you want to still monitor those intermediates as though they're making their own estrogens, and still balance that out so that they're not over experiencing that estrogen. So then we have to then kind of consider, how are we testing our hormones? If we think about all of that taking place in our bodies and all of that happening in order for us to produce and experience and eliminate those hormones, if we're only looking at blood or saliva, we're only capturing those parent hormones. That's all we see. We can capture some of the signals, and that's good information, right? We can capture those peptide responses, those FSH, LH signals. We can look at prolactin. We can look at anti-Mullerian hormone. We can see things that indicate ovarian health and status for sure. But you're not going to see those metabolites, with the exception of course, DHT technically is a metabolite, right, that you can measure. But you're missing a pretty large worldview of what's happening, right, with those hormones in the body. So Pros and cons to each though, right? So serum is a way you can obviously test hormones. It is the gold standard. It is going to reflect the circulating protein-bound hormones predominantly. The free fraction is harder to identify in serum. And I would say, there was actually this study out of Oxford that was looking at testosterone in particular for men, and men make a lot of testosterone. So getting the free fraction shouldn't be that hard. That said, again, free hormone doesn't circulate well in a primarily water-based solution like blood. So when you're looking at that free fraction, what they found was in a lab setting where they have all the advanced tools and all their research assistants that can go in and like really narrow in exactly the free amount of testosterone in a given sample. And then they compare that to what labs just out in the world, the conventional labs are looking at. The values were drastically different, right? And so they found that you can actually more accurately define the free fraction of hormone by taking the total testosterone, the protein bound fraction in blood, and comparing that to sex hormone binding globulin and albumin, because those are the two proteins that are binding to those sex hormones to transport them. So really, a lot of lab panels nowadays will just have them all tacked together, and that's fine. You can definitely order it. Just know that the free hormone assessment in blood, not accurate. You really want to define it yourself by taking the total testosterone and comparing that to SHBG and albumin. And they're called free testosterone calculators. They are free, but it's looking for the free testosterone fraction. And they're all over the interwebs, right? You can go on and you can just type in those three metrics and it'll calculate out that free fraction. And it turns out that's actually a little more accurate than the free that's reported in the actual blood test. And I actually found that LabCorp, I think, is doing that equation for their free fraction for some of their testosterone panels, which is interesting. So anyway, I digress. The other thing you want to know about serum is you want to use, because our sex hormones are actually a pretty small fraction of what's in our blood, right? So we want LCMS. This is going to be ultra sensitive testing. We're trying to find a very small amount of something in a very big solution. We want something that's going to be able to refine that and pinpoint exactly how much is present in that sample. And that's going to be your LCMS. DHEAS is still to this day run as immunoassay, but I believe estradiol, progesterone, and testosterone all have LCMS options, and you want to select that to get really accurate results. Again, our serum labs are validated, right? This is, again, where a lot of the research happens, but it's validated based on timing. Remember, hormones have a short half-life. They do not just circulate indefinitely. We tend to pulse our hormones at greatest amounts in the morning. Although I'll show you a grid here pretty soon with progesterone. Progesterone has a half-life of 15 minutes. When it's being produced, it goes up and down very quickly throughout the day. So it's hard to make sense of serum if you're only getting a single point in time. Again, it's ideal for those peptide, those protein-bound hormones, but it is just a snapshot. We also have saliva, and saliva does have the advantage of being a tissue, right? So it's the free fraction that passed through the tissues. It is prone to interference, especially if you have any inflammation or blood in the gums. That can be cross-contamination into that saliva and over reflect certain hormones, especially testosterone. You're not getting the protein-bound fraction, so you don't know how much existed outside that cell. You just know what passed into the cell. Pros and cons to that. And it does tend to overinflate exogenous hormones based on tissue sample comparisons. With urine, you're seeing that bioavailable hormone. To be a metabolite, the hormone had to have been unbound at some point and freely passed into that tissue and then transformed. So it is a waste product, but it's showing us, if we reverse engineer the waste, right, it's showing us where that hormone had to have come from and which enzymes were involved in that breakdown process. Again, it's revealing our metabolites. And it's capturing a daily average. It's not a single point in time. It's an average throughout around an 18-hour window, or even a 24-hour window if you're doing the jugs, right? You're not getting the protein-bound form of those hormones. So again, you're missing out on the total circulating amount, but you are seeing what was most active and how that was transformed in the body. It tends to overinflate the oral and sublingual hormones because of first-pass metabolism, and it is subject to the UGT deletion, which is a fairly common deletion. And it's going to augment how much testosterone clears into urine. So always good to run a serum testosterone for confirmation anytime you do a urine analysis for that reason. So what would be the value in each? Well, if we think about it, our brain is sending a message, right, to the ovary or to the testicle and saying, hey, we need to make some hormones, right? We need to develop our secondary oocytes or we need to develop some sperm, right? We need to make some hormones. So we're going to send a message down. LH and FSH hit on those external receptors. I think of it as a knock on the door, telling the factory, let's ramp up hormone synthesis. A fraction of that hormone is going to be loaded onto VANs. This is going to be the sex hormone binding globulin predominantly, as well as albumin. And this is going to circulate it out into the tissues. So that's what we're capturing, right? Is how much hormone got circulated out on the VANs. In saliva, we're seeing what got dropped off at the house, right? We don't know how much was on the VAN, but we know there was something dropped off, and we can make some sense of that some of the time. And then in urine, we're seeing, okay, what was dropped off, and then how was it unboxed? How did it break down, and how did we fully, get rid of that product ultimately at the end of the day? So really a much greater view, I would say, of what's going on hormonally at a cellular level. So again, with serum and saliva, what was there at that point in time of testing? Urine, what was there and what was cleared out, and how was it cleared out, and how can we assess what that's doing metabolically to our bodies over roughly an 18-hour window of time. So again, why does 24-hour matter? Well, as I mentioned, progesterone is super bouncy. It has a short half-life. Women are only going to make the bulk of their progesterone for around 10 to 14 days out of the cycle. It's made, as a reminder, from that corpus luteum, which is only formed after the successful rupture of a follicle, the release of an egg, and that kind of atrophy of the follicle, right? So that's when we're getting that bulk bolus amount, but that tissue is finite. And so it produces out and then drops and then produces out, and then we use it up, and then it produces out, and then we use it up. So you can get up to an 80% change in progesterone in 90 minutes. And from this study, the researchers were saying, if you want to accurately understand progesterone in the body, you're going to have to collect 4 serial collections throughout that 24-hour window. Who is going to do that? What patient is going to sit down and go to a lab 4 times during the day and be poked, right? These poor women were being poked every 30 minutes. So pretty remarkable. But this is, great data to see. Testosterone. We know that testosterone tends to peak in the morning. And for men especially, they're going to reach that maximum output by 11 a.m. And then the rest of the day kind of drops depending on metabolic response. You can get little surges if you're being more anabolic, like if you're going to the gym or you're running, but there tends to just be these like tiny little waves. Estrogen has a lot more variation. It does tend to pulse more in the morning and like early morning. We're talking like 4 to 6 in the morning. It gets its like pulsations, but it's also going to pulse to cortisol. It's going to pulse to our FSH signals, our insulin response, aromatase, right? So there can be a lot of variations throughout the day causing these peaks and troughs in estrogen. And again, if you're testing just at a single point in time, if you're not taking in all those other factors, we don't really know what to make of that information. Did you collect at the right time? And I'm going to give you a case study showing just how important this is versus did you collect over that full day and you're getting all the peaks and troughs averaged out and you're getting your total daily tissue burden when you're looking at urine. So that's where EndoAxis comes in, because that's a lot of information. That's a lot to think about, right? It's like there is so much value with urine, but to have to put together all those pieces, that takes time. And you really have to sit down with the information and you have to put those, like each of those connections together. That's what EndoAxis is doing for you. We are a streamlined technology that's really taking all of those pieces where basically we built in these logic equations and these different algorithms that are factoring in all the parent hormones, all their metabolites, all enzymes involved in production and clearance of those hormones, and then saying, hey, this is what the end product was on this test. Here's what pattern they fall into for their sex hormones and their adrenals. And here's some unique findings and some variables that you want to consider as you're assessing this patient. And again, we're predominantly not even a tech company. We are a tech company. That's what our baby project is. But we are also a supplement company. And the supplements are targeting those enzymes. They're not targeting the hormones. So we're assessing these labs, and we can look at a Dutch Plus or a Dutch Complete because we do want the adrenal information as well. For males and females, it looks like Monday through Friday on there, but it's males and females. You do fill out a symptom tracker, and that symptom tracker, we partner with some of the metabolites. So for example, if you have someone who's really struggling with acne, and their 5-alpha metabolites are quite high, maybe they're not even high per se, like respective or overtly high on the dials, but in respect to their other metabolites, they are showing stronger preference for 5-alpha androstenediol or androsterone or DHT. We call those out and we say, hey, don't miss this. right? Like the dial might say it's balanced, but they have pretty robust levels, for example, of DHT. That's going to be 4 times more potent than testosterone, right? So this is going to be something that could be driving that acne picture. Or maybe they're struggling with acne and all their hormones look great. And it's like, well, no, cortisol is actually pretty high. Think about cortisol being a driving factor of inflammation as it relates to the skin. And then you get these personalized reports and custom supplement recommendations. So how are the reports delivered to you? You're going to see a report similar to this. It just expands on itself. You get a little snapshot of what the pattern kind of hierarchy is. So what were the big things not to miss on this report? And then we grow that information from there. We have hormone insights, which starts to relate the hormones and their enzymes to one another. It brings in environmental factors and really discusses more of those enzymes involved. And then the strategy and analysis dives very deeply into the enzymatic responses and environment, gut, diet, lifestyle factors, all the things that could be playing a role in why that presentation looks the way it does for that individual. We have 236 female patterns. So as we're relating all of these hormones to their metabolites and trying to figure out what type of imbalances could exist, 236 imbalances exist for women. And those aren't even the end all. It's actually 236 times 4. So we have irregular cycles factored in. We have whether or not they're on birth control, whether or not they're postmenopausal or have surgical menopause, whether or not they're on BHRT. That can all factor into the comments being displayed for you as a provider. So it really does become unique to that individual. We have 96 male patterns and we have 14 adrenal patterns. And we have our 26 formulas, and we're constantly expanding on these. But again, we wanted to start with the blends that are really targeting the highest level of imbalance identified in all of those patterns. We numbered them because they're not really treating hormones, right? It's not like this is our PCOS blend, or this is our PMS blend, or this is our estrogen detox blend. It's more, this is our blend that's targeting upregulated CYP17A1, downregulated CYP19A1, and elevated SRD 5A1 and 2, right? So that would be like our PCOS classic presentation, and that would be Formula 10. And so we didn't want to name them because they're really enzymatically driven, not hormone driven. But our harmonized blend, we did categorize them. So harmonize are the female blends, restore is restoring function to our detoxification pathways and detox enzymes. Optimize is optimizing function to hormone regulation primarily through the adrenals. And then enhance is enhancing male hormone. We have 3 of those guys. And just to show this in real time, because I know we're running short on time. Sorry to blow through this. But I wanted to share a case with you because this was actually a case I submitted to our program early on and was like, this is great. So we have here a 28-year-old female. She's Hispanic. She has regular menstrual cycles, slightly overweight, BMI of 30. Her cycle length is pretty regular, 26 to 28 days, with a menstrual flow that lasts 7 days. And she began experiencing really heavy menstrual periods at age 23. Her OB-GYN at the time was like, just go on birth control. Totally controlled it. She felt great. She was like, okay, but now I'm married. Now I want to come off the birth control because I would like to start a family. But every time I try to come off birth control, I get really heavy periods again. What's going on? So I said, okay, well, let's start with some labs. And we did do her blood work. And I wanted her to collect on day 21 because we wanted to see, is she ovulating? And day 21 is going to show us if she indeed successfully released an egg, created that follicle that then transformed into an optimal corpus luteum. That's our fertility cycle right there, right? So wanted to know, what is her estrogen progesterone ratio at that mid-luteal time? Did she ovulate? What is her progesterone range? Is she estrogen dominant? Right? I was concerned that she might have a lot of estrogen based on her symptoms. This was her day 21 results, and you can see her estradiol was 29. It should be 56 to 214. I was expecting her to be in the 180 to 200 range based on her symptoms and age. And here she's sitting at 29. This is like a postmenopausal woman, right? That's weird. Head scratcher. And I was like, well, maybe she collected at the wrong time in her cycle. Maybe she's, collected during her follicular phase, like that day 3. But then I looked at her progesterone, and progesterone's 15. Remember, progesterone over 5 nanograms per milliliter is consistent with a successful ovulation, is consistent with an endometrial response and a corpus luteum generation of progesterone. So 15, this is a pretty good range for fertility, right? We like that range. So she obviously collected at the right time, but what's going on with that estrogen? Testosterone for her age, now she's in her mid 20s, she's 28. So 16, I don't love that, right? Like, I'd like to see her in the 30s for total testosterone. SHBG is a little on the higher end than I'd like. Usually, 50 to 85 is like kind of an ideal target to optimize hormone response, but also balance. So 91, it's like, and one of the number one drivers, right, of SHBG synthesis in the liver is estrogen. So I'm like, she definitely fits symptomatically with high estrogen picture. She seems to be generating protein in response to suspected estrogen, maybe. Seems to be ovulating just fine. What's going on? Then we get her urine as well. I said, do them both on the same day, ideally. And she did. And these were the this was the result from her urine. And we can see her estradiol is actually quite robust. Estrogen's looking weird, right? What's going on there? But estradiol looking great. Estriol through the roof, 16OH. Wow, right? That's her heavy menstrual flow right there, right? She actually turned out, so based on this and her symptoms and concerns, we decided to just do a pelvic ultrasound, and it showed very small, like a 2 millimeter fibroid. So she's definitely creating, this is a tissue grower. 16OH is associated with endometrial thickening, with fibroid growth, with fibrocystic breast changes, with cysts. Yeah, totally fits her symptom picture. This is her estrogen dominance, right? Just that's high 16OH. So when I ran this through EndoAxis, I was like, okay, what's this discrepancy? Why is estradiol looking great here, but looking so low in her blood? And so I asked her, was this collected on the same day in the luteal on day 21? Yep, totally. Okay. Turns out she collected after work for her blood test. So I had asked, well, did you go in the morning, right? Because we know that's when optimal peak levels of hormones should be reaching their most robust. And she goes, no, the morning turned out to be really chaotic. I was able to do my urine samples, but I couldn't go into the lab until after work. So here, kind of following that trend of what hormones are doing, we expect hormones to be on the decline in the evening, and she was, right? We missed it. Had we only gone off her blood, we would have been thinking, oh man, she's like estrogen deficient. This is weird. Probably scratching our heads a little bit. But yeah, here we see in urine, no, her daily average actually looks pretty good. So she was given sex hormone pattern 113. And this is, speaking to progesterone being in a nice luteal range, estrogen also in a luteal balance, but 2OH not being the favored hormone. We want to see 2OH preferred. And yet in this case, she's pushing more 16OH, and this can increase the chance for that oxidative and proliferative potential of those estrogen intermediates. Testosterones look pretty balanced. And so we really want to focus on detox with her, and I would agree. It also called out that 16OH and E3 are super high. What do we make of that? Well, in the strategy and analysis, the deep dive of that pattern, it's calling out that 16OH compared to other metabolites was elevated. These are things that drive up CYP3A4. That's the enzyme responsible for that conversion. It is a proliferative intermediate, and there are things that can slow production or support more of the 2-hydroxy without lowering overt estrogens like resveratrol, sulforaphane, rosemary. But that really, 16OH, this is dependent on glucuronidation and sulfation. So you want to consider biliary and GI support, right? Not all detox is created equal. If we're looking at estrogen detox, I don't want to necessarily give her a bunch of DIM because her estrogens weren't necessarily high, right? And she's actually been on DIM before and she feels awful on it. She says she starts noticing hot flashes, her cycles become really irregular because she doesn't really have the estrogen to sustain that DIM response. Yeah, it was probably pushing her CYP1A1, which is the whole point, of using DIM is to enhance CYP1A1 expression, but in doing so, it can pull out that estrogen as well, and she doesn't have a lot. She just has a lot of 16OH. So in her case, it's saying, okay, let's focus on biliary and GI. It's also pointing out this weird discrepancy, right? Estrone and estradiol. And we see that, estrone in the presence of in-range estradiol. Estrone is both produced in the gonads as well, so the ovaries in women, as well as the adrenals. And when DHEA is low, we can see poor conversion of DHEA to estrone peripherally, but that estradiol is heavily produced in the ovaries. And so if estradiol is looking pretty good, then we know, well, the ovaries are actually sustaining hormone synthesis pretty well. It's likely the adrenals that we need to support. And you can see that called out. Here we see DHEA is low. So yes, absolutely fits. And then it's also going to call out, well, yes, DHEA is low, but 16-OH is pretty high, right? Be careful with DHEA supplementation. So low DHEA in the presence of normal or high estrogen is another flag that we will pull out in our reports. And here we say, most of that DHEA is adrenal derived. It can aromatize. And it can aromatize into estrogen as well as 16-hydroxy that can push that 16-hydroxy synthesis. So even if estrogen themselves are not high, if 16-OH is favored, you could be driving up estrogenic response. And DHEA, especially if there's fibroids present, concern for endometrial hyperplasia, it's like we don't want to be pushing DHEA. So focus on adrenals. That's what this is kind of summarizing. It's saying you may want to focus on the adrenals first and focus on gut and biliary health, and then come back to the DHEA if she's still low and struggling with symptoms. So in our case, we have 5 detox products just to shine light on these guys. Always work in reverse order when you're looking at detox. We always want to make sure that the dump trucks are making their way to the dump appropriately before we start bombarding them with tons of trash bags and tons of piles, right? So always work in reverse order. Start with the dump trucks, work then on optimizing and maximizing trash bags, and then you can start increasing those piles. Never inhibit phase 1, because phase 1 is not just clearing out estrogens and testosterone and progesterone, it's also supporting a lot of metabolism of our medications and environmental toxins as well. So we don't want to necessarily inhibit things like 3A4. We don't, in her case, we would not want to inhibit CYP3A4, but we would want to ensure that she can optimize that clearance of 16-hydroxy through gut support. Just to put this into perspective, we have 5 products and they're focused on various imbalances that are responsible or could be responsible for estrogen metabolism errors. If you go to a catalog of lots of different products on the interwebs and type in estrogen detox, there were 320 results right in this catalog. In particular, this is a professional catalog for supplement containment. I don't think I can name names, but I just pulled out a few of them, and really they're just variations on the same theme. They're going to throw in some DIM, they're going to throw in some sulforaphane for that methyl support and for hydroxy reduction. They're going to throw in an homage to the calcium D-glucarate. Therapeutically, calcium D-glucarate to have any impact on estrogen conjugation should really be about 500 milligrams per day, ideally 1 to 2 grams if they're really estrogen dominant. So when I see calcium D-glucarate at like 100 milligrams in these products, I'm like, okay, maybe helping, not really though. Some great antioxidants, but it's really like throwing everything. It's like the kitchen sink into these formulas. This one in particular did not have a lot of methyl support. This one did. It had that methylfolate and B12. Again, the DIM, when you're looking at ingredients, ingredients matter. We really want bioresponse DIM if we're using DIM, right? If it's indicated, because that's a choline added, like a fat, a liposomal, essentially, liposomal DIM that really helps ensure absorption and liver support, liver focus of that really potent antioxidant. So it does show better reduction in estrogen clearance. It's definitely more liver focused. Seems to work really well in the research around it, which is why it's patented as bioresponse DIM. So when you're not seeing that, like if you purchase that, this is what we use in our products as well. If you're just purchasing generic DIM, you don't get that patent. And you want to be careful there because not all DIM is created equal. And then like this was a nice receptor response, but again, it's mostly just like liver focus without a target. Our product recommended to this patient was Formula 11, and this is our gut and biliary supportive blend. So here we're seeing, we always use minerals as cofactors. They should be driving agents, but not bombarding the actual absorption of the rest of the nutrients within that product. So we're not using hundreds of milligrams of magnesium because that's a very bulky mineral. Instead, we're focusing on the amino acids and the herbs. This one's not a heavy herb product, but like a lot of our blends are herbal focused. And so we want to focus on those star players and use the minerals as synergizers, working really more in a hormesis response. But you can see our calcium D-glucarate in 2 caps is 500. If you wanted to double the dose, you could even triple the dose. You could do 2 once to twice a day and really maximize that CDG. We're also giving you a lot of sulfation and biliary support with the taurine. Trifala is a beautiful Ayurvedic combination that supports liver, it supports gastric motility. It is a prebiotic, so it's supporting biliary, that bacterial focus and that like microbiome. It does have some digestive enzyme support and of course our choline for liver and for estrogen clearance. So just a really nice blend, giving her what she needs without all this extra, right? Without all of these aminos to get, that sulfation support, or without having to add an additional calcium D-glucarate to get her to the right dose. So just to give you kind of an example of one of the products and how our blends work together, we really support in a foundational way. So you'll get usually 3 recommendations. So it's usually a hormonal blend, detox blend, and adrenal blend. You don't have to use them all at once. You sometimes will get complement blends or things you can swap out as well, depending on the patient and their age and what's popping up on their reports. But our products are really intended to work with one another. So the more dysfunction there exists within a pathway, the more those minerals will build up into ranges that become a lot more therapeutic. And a lot more of those herbs will begin to work synergistically in tandem. So it's like you don't maybe need all of that if you're looking pretty good and you just need one product, right? But if you're looking like, oh yeah, there's all of these errors in metabolism and here's 3 blends that you really would benefit from, you're going to see that and they all work together and enhance one another. So they kind of build and just add to the beauty and magic, of the products. And I always like to point out, when you're working with hormones, you are going to get a lot of information. You are going to get a lot of recommendations, potentially, depending on the patient. It's always great to remember the hierarchy of hormone balance. You want to support the gut and the cortisol and the environment first. So the adrenal blends, if a patient's like, well, I don't want to take 3 products, right? You can be like, well, let's just take that optimized blend. Let's just focus on the adrenals while we work on your gut and environment and lifestyle. Or if they're really struggling with that heavy menstrual flow, like my patient was, I'd say, let's really focus. Her adrenals actually didn't look too bad. She did have that lower DHEA, but I'm like, let's focus on sulfation. Let's focus on detox first and environment and optimize sleep schedules and stress level. And then add in our sex hormone blends if needed. So that's kind of how you can think about it. It's like you will get several options. You don't have to use them all. We're really here just to give you insights and information. Think of us as really a professional consultation at your fingertips, right? So we're here to guide and direct, but not to override. You know your patient best. And as you go through the report, the hope is that you start seeing the clues unfold and you see these little, seeds leading you down the right path to what their root cause imbalance is hormonally, what could be driving their symptoms. And then you get some wonderful options that you can pick or choose from. So what you get, you're really getting our personalized recommendations. We do have a Learn Center. It's full of hormone conditions. All of the analytes that we're reviewing in detail are outlined there as well. You get all of the herb and mineral research. You get our YouTube video channel with our case studies. And you're getting our custom formulations, which are CGMP certified. They're free of heavy metals and pesticides. And it was actually a big thing that I pushed for, but we are putting all of these products in glass because we're working on hormones, right? Like we don't want to worry about nanoplastics and microplastics getting into the environment, let alone into our capsules and into our patients' bodies. So these are all stored in this beautiful blue cobalt glass, again, free of those heavy metals and plastics and pesticides, and really highest sourced ingredients. And we're hopefully saving you time and energy by putting all of this information together for you, pulling out all of those unique facets of that hormone imbalance as it unfolds on that urinary test. So you don't have to sit there and worry about getting a consult and combing through the books and putting it together. You can get that consultation just at your fingertips through our EndoAxis platform. So that is us in a nutshell. Sorry to be a fast talker. Hopefully there's lots of great questions and I'm happy to stop my share here. I do have some great references as well if you want to go through the slides. I think you'll have access to these at the end, but this is a QR code. I do want to also specify EndoAxis is a completely free platform. You of course pay for the supplements, but the education, the information, the Learn Center, that is all free. So you can sign up, start an account, even if you don't have labs to upload yet. You could always play around within the system, go to the Learn Center, check out our case studies, have fun with it. Yeah.
Thank you so much. That was amazing.
Okay.
Very informative and yeah, amazing. Thank you so much. Does anybody have any questions? Feel free to throw them in the chat and I will ask them.
I'm not sure if I'm looking at the right place. I don't see any questions popping up.
Oh no, okay, we just got one. Are there any patients you wouldn't use this process with?
So yes. Patients who are on oral contraceptives, if they're having hormonal symptoms, it's likely because of the birth control. It's not likely anything you're going to see in either a blood, salivary, or urine test. The whole point of birth control is to turn off HPO axis. So the hope is that you'll see nothing, right? You'll see flatline, but then that's also like it gives you no information. You can always do adrenal testing. You can always do micronutrient testing with birth control patients. And we actually do have patterns for birth control because people do still test. And every now and then you'll catch something weird, but I would say not usually ideal to spend because these are more expensive tests for sure. The Dutch test, urinary analysis, I think runs 350 if I remember for the Dutch complete. Don't quote me on that one, but so they're spendy. You want to make sure that money is being used wisely. I will say though, on that same vein, we actually have a birth control multivitamin. So it is, so we know with birth control, including IUDs, you can test women with IUDs. Actually, that one is not in this same category. But we do know that birth control depletes folate, magnesium, calcium, CoQ10, vitamin E, selenium, zinc. It depletes a lot of minerals and vitamins. And it's correlated with a lot of kind of gut dysbiosis that can link to vagal tone imbalance and stress, anxiety, and even depression risk factors. And so we have this, I just love it. This Formula 24. Formula 24 is our birth control multivitamin. You don't even have to test your patients if they're on birth control. Give it to them. And it restores those nutrients for them. It's giving you all of those minerals and vitamins lost, in addition to some L-theanine. We use sun-theanine, which is a really nice phospholipid theanine. It's giving some microbiome support. So it's a really nice blend for women on birth control. We do have a cancer caveat. So if a patient has a history of hormone-dependent cancers, I would encourage you test them because you want to see their oxidative stress risk, but you do want to be careful with what you give. And so we actually will pull out specific antioxidant blends and adrenal blends, and not necessarily we'll give you optional hormone support, but it's up to you if you want to use herbs that could potentially bind to those estrogen or progesterone receptors. So that would be like a gray zone. You can totally test them still. Pregnant, breastfeeding women, we can't give you supplement recommendations, but we can give you information about their hormone imbalances. We do have a prenatal coming out. It's not on the market yet, but that will be something that you could use for support when it's out on the market. Trying to think of others. I would say this is a great report and system for our peri and postmenopausal women, especially women who don't necessarily want to use BHRT, or even if they do, to monitor their response to therapy, right? So yeah, I hope, is that clear? Is that answering?
That's great. Thank you. And that same person had a follow-up question, which is, can you use this with other hormone testing, for example, the HUMAP or EndoPlus from Genova?
So we're not interpreting those results yet. Our system was scrubbing data, and to do so, we had to agree, just for cost and the startup, agree to scrub data from a specific test to start as our pilot. So we really wanted to use Dutch because they are a monofocused lab, precision analytical, with the Dutch test because they are a monofocused lab, meaning that they're really putting all of their resources and technology and research into making this the best test possible versus like HUMAP, which is, part of a large catalog, right, of different test options. They're not going to be as dedicated to making that as robust because they want all their tests to be equally kind of on par. So you really can start to see some legs or gaps. So since we're giving diagnostic information or like not diagnostic, but health informed information in our reports, we just really wanted to make sure that we could hang our hat on that information and felt like precision analytical would be a good pilot project. Not to say we're not going to expand. So long story short, no, we don't do those other tests yet.
Now, but maybe in the future. Yeah, awesome. Next question is, how does this work with FullScript? I'm seeing that it wants to connect my account. Is it bought through them?
Yes. So that was the other thing that we decided early on, was that we didn't want to necessarily self-distribute quite yet when there's this distribute company, FullScript, that will house our products and distribute for us. And so we actually decided to partner with them to help kind of ease that process of getting a product to a patient. So you do have to sign up with your FullScript account to link the accounts, and then it'll send only what you want to send to a patient. It doesn't automatically make the plans for you. You still have to select the products and from the report. You can also purchase wholesale on Emerson. So that is an option as well. We are looking into other distribution, but Fullscript is really our premier partner. And because they're just so streamlined in what they offer, and you can pull in, because we don't have fish oils or vitamin D, or and so if you're seeing like, oh, they would be a great candidate for vitamin D based on these findings, and then you test their levels and you're like, yep, they're definitely low. You could add that just straight from the Fullscript cart. So it kind of gives you that flexibility of being able to pull lots of different things in. Yeah.
And then last question so far is, what will make your prenatal unique?
Yeah. So when we were building our prenatal, we wanted to make sure that, it hits all the right marks in terms of the right mineral composition for embryonic development, for healthy and optimal both baby and mom. So really optimizing the right type of iron, using more like we're using bovine iron. So it is not going to be vegan. That is the one caveat. And I have talked to our distribution or manufacturers about this. But it's really doing food grade minerals, right? So it's easy to digest, it's easy to absorb. And we're using a lot of digestive support as well, because we know with our pregnant mamas, constipation, nausea, right, indigestion, these become so problematic. And we want a product that can really help support not just the minerals for optimal fertility, or not for optimal, but for optimal, development of baby and mom's health, but also for making it comfortable for mom during the conception window. So really having, like, we have a little prunus in there, just a little prune, to add like a nice digestive, like laxative support, but not quite, it's not going to be like a stimulant laxative by any means. It's going to have some nice anti-inflammatories. There's I think of our list of things. What else do we have on there? Just like papain, just some good digestive enzymes. Yeah, that's really what's kind of the novel, like the more unique, I think, facets of that product.
Thank you. I think that's it for our questions. So I really appreciate EndoAxis sponsoring this webinar and your time and expertise for this presentation. It was great. If anyone has any follow-up questions, we'll be sending out the slides, and I'm sure that they will field questions should you have more in the future. So thank you so much.
Absolutely. We do have cs@endoaxis.com is our customer support. It is housed by live individuals. This is not like an AI chatbot. You won't be funneled through a bunch of questions. Like you will get a live person either giving you a call back directly or emailing. So I do encourage you to message her if you have any questions, and she gets right to me. So that's
Great. Beautiful. All right. Thank you all so much for your time, and stay tuned for our next webinar announcement.
wonderful. Thank you guys so much.
Okay, take care, everyone.